I'd like to now introduce our second speaker for our presentation today. Our second speaker is Dr. Leo Verhagen, and Dr. Verhagen is going to cover surgical options or treatment options for essential tremor. But before I turn it over to him, I want to just give you a little bit of background about Dr. Verhagen. Dr. Verhagen received his medical degree from the University of Leiden in the Netherlands and did his neurology residency at Thomas Jefferson University in Philadelphia. He completed a fellowship in movement disorders at the National Institutes of Health in Bethesda, Maryland, where he subsequently served as a visiting scientist. And in 1999, he joined the movement disorder group at Rush University Medical Center in Chicago, where he specializes in medical and surgical treatments of patients with Parkinson's disease and other movement disorders. Dr. Verhagen is Professor of Neurological Sciences and the Director and Founder of the Movement Disorder Surgery Program at Rush, and he has authored more than 100 peer-review articles, multiple book chapters, and is the editor of the Movement Disorder Encyclopedia. So welcome, Dr. Verhagen. I'm going to turn it over to you for your presentation.
Thank you very much, Patrick. Appreciate the invitation, and it's wonderful to be with you today and talk a little bit about essential tremor and the treatment options. You will have heard from my good friend and colleague, Dr. Freund, about medical treatments, and I will focus on surgical treatments.
Okay.
So this is a nice picture of Rush, our butterfly-shaped hospital on the Eisenhower. Beautiful view of the city. So let's talk about who is a surgical candidate. But there's a lot of things here that I want to talk about, and maybe it takes a little bit of your time, but I hope you indulge. I want to talk about who is not a surgical candidate. What are the expectations of deep brain stimulation? What is the time for deep brain stimulation? I'll show you a case study, and then we'll talk a little bit about how the surgery is done, what the optimal target is for essential tremor, and what the evidence is that it actually works. So let's go one by one and talk about who are DBS candidates. Well, I think if people have just very terrible tremor that interferes with writing, or with eating, or with drinking, or with any professional activities, or with their hobbies, or if it embarrasses people and they feel socially isolated, and they have tried medications, the ones we talked about earlier, propranolol and misoline, then I think they are good candidates. But who is not a surgical candidate? And that is kind of important as well. So patients that have psychiatric illness, psychosis, depression are not good candidates in general. If there's significant cognitive impairment, so memory issues, then it's maybe not good to do a surgical treatment such as deep brain stimulation. And if there's major medical problems, severe heart disease or so on, it may not be the best time to do deep brain stimulation. But the most important of all of these is that if there are unrealistic goals and expectations. So we're going to talk a little bit about that, but in general, the rule is that expectations are always higher than the best outcome. We try to make the tremor go away 100%, but that's not always the case. So let's talk specifically about what our expectations and goals are with deep brain stimulation for essential tremor. Well, obviously, we want to reduce or eliminate the tremor. And oftentimes, we are able to do that. I usually say that in 90% of patients, the tremor is reduced by 90%. We also aim to reduce the medication. But none of that is relevant if we do not also improve the quality of life. So we need to put everything in perspective. If we eliminate tremor, but otherwise the patient has other diseases or illnesses or reasons not to have a good quality of life, the elimination of the tremor is not going to be that important. So you need to ask yourself, if my tremor is going to be largely reduced, am I going to be satisfied with that? We also need to realize that deep brain stimulation is not a cure. Essential tremor is a progressive disorder. The deep brain stimulation is a very good treatment that suppresses the tremor, but the disease process over the years continues and tremor can get worse. So 10 years after deep brain stimulation, the tremor is maybe not as well controlled as immediately after the deep brain stimulation. So I cannot emphasize enough that realistic expectations are essential. But if you take that into consideration, then deep brain stimulation is a very effective therapy when medications are failing. So when is the time right for deep brain stimulation? At what time do you decide that? And that's a very individual choice. Of course, the medications need to have been tried. They're not effective. Tremor needs to lead to significant disability, but that is different for everyone, depending on how you're employed, what your work is. It depends also on your personality. How much can you tolerate? How perfect do you need to be? And it depends on what things you need to do outside work. What are your hobbies and so on. So in this case, Martha Sidwell is not a real person, but she is pictured here nonetheless as a 71-year-old retired loan officer. And she developed 28 years ago, she developed essential tremor. And it caused significant trouble with her eating, with her drinking. She needed a straw to drink. She needs to help to get her buttons done and to get her shoelaces fixed. She failed several medications. She didn't have a significant medical history other than that she had high cholesterol. And she had noticed, well, a lot of patients with essential tremor notice that alcohol helped her tremor. And she was on a course of drinking 3 drinks a day. So all these things together make me think that she could benefit from deep brain stimulation. She tried the medications. She doesn't have any significant medical issues that would prevent surgery. We don't want her to keep drinking 3 drinks every day. So we offered deep brain stimulation, and indeed, she went ahead and got the surgery done. So that's an example of a good candidate. Now, how is surgery performed? And I cannot go into too much details, but you want to know a little bit about the surgery. So here you see a cartoon of a person who has a deep brain stimulation implanted. And what you see here at the in the chest is the implanted pulse generator. That is somewhat of a pacemaker-like device that provides the current that is then transferred through this extension wire that hooks up here with the actual wire that goes into the brain and delivers the current. That's called the electrode in the brain. The electrode is fixed to the skull, and of course the skin of the skull is completely over it and covering the entire system. Also the skin here in the neck is covering the extension wire, and while you can feel that stimulator, you cannot really see it very much, as it is covered under the skin. So here are the different steps. We need to attach a device called a stereotactic frame to the head. And that's the only part of the procedure that's a little bit uncomfortable. There are 4 screws in the front 2 and in the back 2 that hold that stereotactic frame firmly attached to your head, because we don't want it to move. It's a very accurate instrument, and it's necessary to help guide us to the right spot in the brain. So with that frame on, you get imaged with either CT or MRI or both, most likely, and then a plan is made on the computer to get us to that right spot that we have found on your MRI image. Then the surgeon will drill a hole in the skull. That always sounds scary, but it's really not very painful. It's very safe to do that. And then the lead is being placed into the right spot. We'll test whether the lead is indeed, when we pass current through it, is stopping the tremor and not causing any side effects. And when we're happy, then everything is removed. The lead is secured in place with a cap that covers that little burr hole. And subsequently, a tunnel will be made under the skin so that the extension wire can be placed and connect the DBS lead with that pulse generator that is under the skin, under the clavicle, the collarbone. Testing again takes place, and finally everything is closed up and you're done with the surgery. Now here you see a patient of mine who's getting that frame placed. And I don't know if you can see it very well, it's an old video, but you can see him actually occasionally smile. He is well numbed up with local anesthesia, and he's talking to the doctor as the frame is placed. And after that, interestingly, the brain has no sensation at all. So while you're in the operating room, you are able to talk, you're able to tell me what you feel. I have this patient tap his fingers to show that there's good movement going on. And that goes to say that surgery is, while it's certainly brain surgery and we shouldn't underestimate it, from the part of the patient, it may be scary, but the patient is awake, is talking. Some patients are joking when I talk to them. It is very well tolerated in general. Now, what is the optimal target? Let's look at that. This is maybe difficult for you to see, but this area here, this whole entire colored area is called the thalamus, and the green area is the ventral intermediate nucleus of the thalamus. That's a subnucleus that is targeted in cases of essential tremor. And you can see that other parts are labeled in red. That is another part of the thalamus that has sensation in it. So if we stimulate a little bit closer to that red part, patients feel some tingling oftentimes. And that explains why when we're looking for the best place to place the lead, we're looking for those kind of hints as to where we are exactly in the brain. Now, what is the evidence? Well, of course, there have been publications on the effect of deep brain stimulation on the essential tremor. And it shows that on average, patients have a great result, usually in the order of 90% improvement, sometimes a complete abolition of tremor. So let me summarize by, this is just the first part of the talk about deep brain stimulation. The deep brain stimulation is extremely effective. It does require surgery and penetration of the brain, but once the lead is in there, the procedure is also reversible. Let's say in case we're not exactly in the right position, we can either use our programming to steer the current away from side effects and towards benefits, or if the lead is really not in the right place, we can take the lead out and reposition it. We don't make a lesion. So it's a reversible, adjustable therapy. And over time, sometimes patients need a little bit more stimulation, and we can do that just from the outside by increasing the stimulation intensity on our computer programmer, just from the outside. That is a good segue into the next segment of my talk. It's the second newer surgery that is being offered currently at Rush in Oak Brook, in our Oak Brook facility that's depicted here. And that is called focused ultrasound. And I know a lot of you are curious to hear about that. So the first slide is just an overview of what was done in the 1950s. In the 1950s, and still up till today, rarely, lesions are made in the brain, similar to the procedure with deep brain stimulation. A probe is advanced, but instead of leaving a lead behind, the tip of the probe is heated up and the tissue coagulates, and basically a lesion, a destruction is made, a very small one that is in the area that causes the essential tremor. So that was still done, and it's still occasionally done. And for instance, Michael J. Fox, for his Parkinson's tremor, had that procedure done many years before people knew he had any tremor at all. It's a solid way to do things, but it requires the surgery, penetration of the brain, and it's destructive. Let's skip the gamma knife surgery. I'm not a great fan of that particular procedure. That is using radiation to target a place in the brain. But let's skip to the deep brain stimulation I just talked about. That really came to fruition here in 1997. And since that time, it has largely replaced the thalamotomies, the lesioning that I just mentioned, because it is not a permanent lesion, and it's adjustable over time. The drawback is that you need to put an electrode in the brain, and you need to put a pacemaker in the chest. And when you do something to the brain, there's always a risk that something would happen. In general, the risks of deep brain stimulation the serious side effects are less than 1%, but something could happen to the brain during the surgery. Less than 1 in 100 patients will have something serious with deep brain stimulation. Deep brain stimulation can be done on both sides of the brain. And again, it is reversible and adjustable over time. The newer treatment is called focused ultrasound. And it is done with a machine called the Exablate Neuro. And it was approved by the FDA in 2016. And only this year, just before COVID broke out, Rush got a machine in its Oak Brook facility, and we have been operating on several patients already. And there's significant interest in this procedure. And the reason becomes immediately clear. We're going to talk a little bit about that. So just like with deep brain stimulation, the tremor is reduced right away. It is done by also heating up tissue deep in the brain, but from the outside. There's no penetration of the brain. And I'll show you a little bit how that is done. The safety of it is fairly good. Again, 1% of patients gets a side effect that is maybe still present after a year. And we go into that in a little bit more detail as well. Just like with deep brain stimulation, it does not prevent disease progression. And the drawback of this treatment is it's currently only approved for unilateral treatment, so one side of the brain. So if you have two hands that are shaking significantly, only one will be fixed at this point in time. Whether that's going to change in the future or not, it remains to be seen. So here you see a picture of a patient that is in the MRI. So I didn't mention that yet, but that focused ultrasound treatment is being performed in the MRI scanner. So we take live pictures of you in the MRI. We can see your brain, we can see where we want to go and where we want to focus our ultrasound waves on. The patient here has a similar frame as I showed you for deep brain stimulation, again with the screws, so that's the same. And the patient is also awake. And now he has something on his head. There's two parts to this. There's a bladder filled with water that both cools the skull, but also helps make excellent contact between the skull and the device around here, which is depicted on the next slide here on the left-hand side. So what you see here on the right-hand side is the same. This is dismantled on the left-hand side. And that is called a hemispherical transducer. It in fact has 1024 little elements in there that provide beams of sound that come from all these different directions and then come together on one focal point. And when all these focal sound waves come together in that one focal point, that's where the temperature goes up, and that's where a small lesion is made in the brain. So again, all from the outside. Each individual sound beam doesn't do anything to the brain, but when they all come together, it's similar to when you hold a piece of glass in the sun, and the sun shines down on the glass, and some object below the glass could catch fire because the light beams in that case come together and heat up a specific point underneath the piece of glass. Maybe you've done that when you were young. So this is not light waves, this is sound waves, but the principle is the same. So this is a nice picture how you would be laying into that MRI scanner with the device on your head. And here are the different steps. So the patient is prepared by the physician. Then the operator sits behind the screens, looks at the MRI scan, says that's where I want to be, and then focus ultrasound will take place. The beauty of this is that, yes, we're heating up the tissue, as you can see on the left-hand side, but we can do that very gradually, and we can do that up to a certain limit. So we can increase the tissue temperature to about 45 degrees. And at 45 degrees, everything is completely reversible. And this is what is being done so that we can test while the patient is laying there in an MRI scanner if the tremor is better and if there are any side effects. If at 45 degrees there would be a side effect or the tremor doesn't get better, we can lower the temperature again and no damage is done whatsoever. It's completely reversible. When we find out that there is an excellent tremor control from just stunning that tissue at 45 degrees and there are no side effects, then we know we're in 100% the right place and we increase the temperature to what's depicted here, maybe 60 degrees, and that will create a permanent lesion. At the end of the procedure, an MRI is done and we'll show that there is a little white dot there, that is the lesion that's been created. And the patient then stays for about an hour for observation and then goes home. So here you see what can happen immediately. This is the spiral before, and on the right-hand side, the spirals afterwards. On the right-hand side is what I just explained. We increase the temperature maybe to 45 degrees. Then we find out that the tremor is gone, that there are no side effects, and then we increase the temperature more, and that's when we get ablation or destruction, and the lesion is becoming permanent. So here you see what's happening. The tremor is present, doctor is testing. This is a TV doctor, by the way, and this is a TV patient. It's not a real patient and a real doctor. The patient is moved in the MRI scan. The operator looks at the MRI scan of the patient and targets where the lesion is to be made. This all takes together probably 2 hours. There is real-time monitoring and thermal feedback. I never knew that. The MRI actually can give you an accurate estimate of or determination of the temperature of any particular part in the brain immediately with a 0.1 degree accuracy. So we know exactly what the temperature is. The doctor is testing it again. There are no side effects. The tremor is already better. That is the sonication when you see those beams go to the focal point, and as a result, the tremor is immediately better. So this is a very attractive treatment. Afterwards, you see this little lesion in the brain. This is a brain MRI sliced in a horizontal way. You see the eyeballs in front, and you see that's the lesion. And when you enlarge that, you see that initially there will be a lesion in the center. There will be a little bit of edema around it that ultimately will be part of the lesion, and there will be another area around it that is also swelling, and that swelling will go away, which means that initially the lesion seems to be a little bit bigger than it's actually going to be, and sometimes people do feel a little bit of tingling or a little bit of unsteadiness after the surgery that then subsequently resolves. And this is a picture of the side effects that can happen with this procedure, and there are plenty of side effects. They can be listed as mild, moderate, and severe. And let's look at the severe side effects on the right column. And there are very few. In this particular cohort of 186 patients, 5 patients had a severe side effect, 1%, which is kind of similar to what happens with deep brain stimulation. The side effects are, of course, different because we don't go through the brain. So there's no real chance of a stroke or a bleed. But you can imagine if you're not exactly in the right spot and you make a lesion, you could get a side effect. So if you're a little bit too far one way, you could get paresthesias. Those are sensory phenomena, basically tingling, and that can persist. But if it persists, it's mild or moderate, and no severe tingling was reported in this cohort of patients that was studied. There can be some balance issues. Again, that only happens if there's a little bit of expansion of the lesion that is unintended into an area that we don't want a lesion. So with increasing experience, I think those numbers are going to go down further and further. Now, how effective is it? This is a 2-year follow-up study from the initial cohort that was studied. You see at baseline, the tremor score here, doesn't matter what the units are, but it goes down by about 50% and it remains stable for 2 years. The same thing here as far as how is the tremor affecting my ability to do things. So this is a disability score, and the first one was a pure tremor severity score, is much improved again, and that may creep up a little bit after 2 years, but it's still so much better than here. So after, but you see here on the right-hand side that the response can vary. This is percent improvement, 90% improvement in some, 80%, 70%, and about 50% of patients have about 50% of improvement in their tremor after 2 years. That is not as good as what I mentioned from about the deep brain stimulation. And I think on average that is true, even though the outcomes are getting better and better. At the current time, I think it's reasonable to expect perhaps a 75% improvement on average. You can imagine that with going back to the deep brain stimulation, which is reversible and adjustable, that you can increase the intensity of the stimulation. And think of that like a little balloon that you blow up slowly when you increase the stimulation. A balloon, a virtual balloon of electricity, of the electric field around the wire. You can fine-tune that and increase it as much as you want until you get side effects, and then you can back off. You have that reversibility. With this procedure, you need to make a lesion that is permanent. So if you make the lesion too large, you get into side effects. If you make it too small, it's not effective enough. So it becomes an art to really get the right size lesion. And if you push your luck too much, you aim for the 100% reduction of tremor all the time, you're probably going to have some side effects in some patients. So I would say it is reasonable to expect about 75% tremor improvement. And of course, we all hope that we're luckier and get a little bit more. So just to go over the benefits again of this treatment, there's no incision required. The patients are awake. It is done on an outpatient basis. You go home the same day. With deep brain stimulation, there is an incision, there is a penetration of the brain. That can be done awake as well. It can be done asleep, but we usually do it awake. There is little to no chance of infection with deep brain stimulation as well. And patients with deep brain stimulation are staying overnight and then go home. So this focused ultrasound is even more of an outpatient surgery. The tremor improvement is immediate. That's the same with the other procedure. Patients have a maintained benefit after 2 or 3 years, and quality of life is improved as well. That counts for both procedures. It's a personalized treatment. Of course, each individual is tested during the surgery for benefit and side effects. And if needed, the focus of the ultrasound is changed. It's effective and safe, even though there is a possibility of, even after 1 year, in a very small number of patients, of some side effects. Again, I want to emphasize this is a procedure that is done on one side of the brain, so only one side of the tremor. If you have tremor in both hands, only the right side or the left side, whatever you choose, will be treated. I think the other important thing to mention is that email address underneath here, that's neurofuzz@rush.edu. That's a centralized email because there are a lot of people that are interested in this procedure. The other thing, a final thing to mention is that there's no real age limit so far. So with deep brain stimulation, because we go through the brain, we don't like people to be too old. With this procedure, since it's from the outside, if a person is overall in good shape, then age should not be playing too much of a role. My final comment before I sign off is that if I compare the two treatments, I think for people who can tolerate deep brain stimulation, who are a little bit on the younger side, I think that is at this moment my preferred treatment because it's adjustable and we don't destroy brain tissue. But if people have unilateral tremor and are not great DBS candidates, I think this is a very nice new and effective treatment as well. So if you want to be evaluated for this particular procedure, write to that email that I've listed here, and I'll be happy to see you in clinic and tell you what I think the best option is for you. Okay, I thank you for your attention. I'm going to send it back to Patrick.
Awesome. Thank you, Dr. Verhagen. Hey, a couple quick questions before we wrap this up.
Yeah.
One question that we get a lot is with DBS, if you have a pacemaker, can you also do DBS surgery?
That's a very good question, and it's always a little bit complicated, but it can be done. It depends also a little bit on what kind of pacemaker you have. If you have an MRI compatible pacemaker, then yes.
And the same would apply then for focused ultrasound too, if it's MRI compatible?
With focused ultrasound, I do not have enough experience, but I think it's absolutely true that you can have if it's MRI compatible, that wouldn't be a reason that it wouldn't be possible. So my answer for that is yes as well.
Okay. And the question we asked Dr. Frank, we also wanted to ask you to get your opinion because he was curious what you thought. Another question we get a lot is, can ET turn into Parkinson's disease?
Oh, yeah, that's a difficult one. So I think the answer is that there is some kind of link between the two disorders. So it starts with our realization that patients with essential tremor have an increased incidence of family members with Parkinson's disease and vice versa. Patients with Parkinson's disease have an increased incidence of family members of essential tremor. So there is some kind of link. And if we look at individual essential tremor patients, there is a minority, but there is a number of patients that after perhaps 20 years of essential tremor start to have signs of Parkinson's disease as well. It's definitely not guaranteed that if you have one, you get the other, but in a small number of patients, you can have postural or action tremor, as we call it, in essential tremor, for 20 or longer years. And at some point, there will be a little bit of a rest tremor coming out as well, which is a typical feature of Parkinson's disease. And then it can become associated with some other features such as slowness or gait difficulties.
Great, thank you. Okay, so want to thank our speakers today. Thank you to Dr. Frank and Dr. Verhagen for taking time out of their busy schedules to speak with us today. We hope you found the information that they shared with you beneficial and helpful, and hopefully you learned something new today that you didn't know before. If you'd like to find out some more information about essential tremor, please visit the IETF website at essentialtremor.org. It's a newly designed website, very user-friendly, very mobile-friendly now, so you check it out on your phone. Or you can give us a call on our toll-free number that is 888-387-3667. So just give us a call and we can try to answer your questions. Finally, I want to say if you are a donor to the IETF, we appreciate your support. If you are not a donor, we hope you consider donating and letting us continue to provide these educational type events with your donations go to help us do those type of things and continue to promote our education and our awareness and our support groups and all of our research that we fund. So we're going to be hosting several of these virtual ET education events over the next several months. So keep your eye out on your email, on your social media, on your Tremor Talk magazine, and when those will be available on our website and other places. And again, thank you for joining us today. Thank you to Dr. Frank, Dr. Verhagen, and we hope you all have a great day, and we will talk to you at our next event. Thanks again for joining us.